So Dr. Alvarado, you can read his bio in your booklet. I'm just going to mention a couple. I'm just going to do the highlight reel of this because I want to make a comment that's not in the bio about him. He is the 15th commissioner of the Tennessee Department of Health and spent over a decade in public service, and in 2014 was the first Hispanic member elected to the Kentucky General Assembly. That's a big deal. I'm a fellow Kentuckian, so that's a huge accomplishment. What I want to say about Dr. Alvarado is it's not very often that, in my experience, that you have a leader who will show up to the local health department. When Dr. Alvarado came to Tennessee as our commissioner, he went and visited every health department in the state of Tennessee. And from the very beginning, and Don came too, so we got to meet his wife. We say that's the boss, but but he very approachable, very personable. And he's just someone that sees you as a person and not as just an employee. He comes to the front lines. He shows up for you. And in 2023, he came to TPHA, and he gave a presentation. He did his talk, and he mentioned the Blue Zones documentary. And it took everything. I'm not a very patient person, but as soon as he was done talking, I tried to get to him, but so did everybody else. And I was just trying to tell him, in Severe, we're having this conversation, but I didn't have the clout to get people into the room. People trusted me as a public health professional, but I needed some muscle behind this, and I needed some support. So Dr. Alvarado agreed to come to Severe. He spoke to us. He's been to other communities to talk about Blue Zones. And I just want to recognize that leadership, that he will roll up his sleeves, he will show up for you, and that's something that we need in our health commissioner, and I very much appreciate that. And this is not just for bonus points or brownie points or whatever, but I want to welcome Dr. Alvarado, our commissioner.
Well, good morning, everybody. I appreciate that last presentation. I still practice clinical medicine, so I do long-term care. I've been doing that. I've done primary care for a long time, and through a long series of events, I've kind of found myself in the long-term care world, but I've done that from the beginning. And when you mention a patient, the 80-year-old with Parkinson's who gets weaned off all of her meds, I often tell people that the best treatment course for some of the patients I have are the ones who get admitted to hospice, because they're on their way out, they're like, oh, they're dying. Stop all their meds. And a year later, I'm looking at them, and they're looking great. I got one right now. I got a call this morning, got taken off of hospice. A guy who'd been readmitted to the hospital, I can't tell you how many times, was on his way out the door. Stop all of their medicines, and you wonder how much more damage are we doing sometimes with the medicines that we're prescribing than just letting things take their course. So it's always interesting, but that's a true scenario more and more. It's polypharmacy and the things that we're seeing happen for folks that are out there. So, I appreciate that. Let me make sure this, I just hit the button and let it go, I think, right? Or forward? There we go. All right, very good. So let's start off with kind of a little bit of a talk about the agenda is kind of the why, of a little bit of background about the department, and an overview of the things that we do, the what, some of the wins that we've had, I think, last year, and really the state of public health in 2025, and maybe a little bit about the future of public health also in Tennessee. You kind of hear about my background. I've got a bit of a political background, and it's always interesting to be able to leverage some of that, some of the relationships I've had with legislators here in Tennessee. Just from the time that I was in Kentucky, there's a lot of national organizations you get to be a part of. And coming here, having known a lot of those legislators already, and I often tell people that I've got really the best department in state government. When I talk about the what of what we do, it reflects on our why. And you can see here the mission, the vision, and values is to protect, promote, and improve the health and well-being of all people in Tennessee through our core values of excellence, service, compassion, and trust. And really, when you look at the trust factor, we talk about that. I've often talked about the difficult time that I think departments of health have had coming out of the pandemic, when we've left that with a lot of people questioning government more than ever before, not having a lot of trust, sometimes through no fault of our own, often through national decisions that have been made. But people are starting to doubt what we do. And so I think as we've reevaluated what our values are, we put down trust, because we want to make sure that we show up where we're supposed to be and become predictable for people. The people who like us will expect us there. The people who don't like us are going to complain about us, but where we're supposed to be. And if we keep doing that over and over and over again, trust comes from that. And I want to start out with kind of some of the big wins, which I think are reflective of these values, and to lay out how we see the challenges and the opportunities in the years and the months ahead. You know, when I first started in this role, I sensed that maybe the morale was a little bit down. Again, we were coming out of that pandemic, and we had some rough years and a lot of transition with our staff as well. And my charge to our team again was, again, go meet our communities where they're at, listen to people, be predictable, build trust. And so the response really has been immense, and there are just a few of the images of groundbreaking and ribbon cuttings that we've gotten to do for rural hospital openings, project expansions, and new and improved health departments all across the state, opening dental operatories and providing services to Tennesseans in need. I'll get to go to a couple more of those in Greene County and Hancock later on this morning. I brought my overcoat and a shovel, but we'll be doing some groundbreakings in some very cold weather. Our staff has been able to really present giant checks to many of our partners who are investing hundreds of millions, building hospitals and housing and upgrading medical technologies and expanding the use of mobile medicine. And you know, the Department of Transportation gets to do a lot of this around the state. They get to present checks, but we're working really hard to move our department into a more visible role in supporting community-led public health efforts. And I've also had a chance to talk to some of a lot of our businesses and the chambers of commerce to let them know I need their help if we want to start improving health outcomes. It's in their best interest for the costs of what they do to be invested in this, and their voice would be a strong one, particularly with legislators and local officials. I've been really happy at how many of our legislative partners have joined us at a lot of these events, and it's been really a great way for us to improve their awareness of a lot of basic public health and what exactly it is that our staff do on a day-to-day basis. And we should have more to say about that in the upcoming weeks, which I'm really very excited about. And at the same time, I think we're expanding our capacity and our service lines. And it's been a lot of work to put a lot of these investments in place, but we're starting to see them pay off already. So the department, of course, manages 89 rural counties with 6 metro health departments reporting to the local government. And over the last 2 years, as Emma mentioned, I've visited all 95 counties, almost all of them multiple times. And because that's really what it means to be a good teammate, I think, is to make sure that people know. And if people want to see their leadership, that we get, I think when we started, people were saying, well, they don't know what we do here in our health departments. And so as a teammate, I've learned a lot about the folks in our health departments in my travels because, and I've also learned from a lot of people and just citizens that I've gotten a chance to run into because Kentucky and Tennessee have a lot in common, not just the shared names of towns and cities that are found in both states like Louisville and Winchester and Clinton, Martin and Brownsville. Tennessee and Kentucky also share the names of 33 counties: Anderson, Campbell, Carroll, Clay, Cumberland, Fayette, Franklin, Greene, Hancock, Hardin, Henderson, Henry, Hickman, Jackson, Jefferson, Johnson, Knox, Lawrence, Lewis, Lincoln, Madison, Marion, Marshall, Monroe, Montgomery, Morgan, Perry, Robertson, Scott, Shelby, Union, Warren, and Washington. All of those are found in both Tennessee and Kentucky. When I mention them, I can picture them on the Kentucky map. And I've got a little website called Sporkle that I think JW has turned me on to memorize where the counties are in Tennessee, and I can see them in Tennessee. But thanks to the grace of partners like you all, I've learned that Fayetteville is in Lincoln County, Lafayette is in Macon County, and the county seat of Fayette County is Somerville, near Shelby County, and Shelbyville, of course, is in Bedford. Decatur isn't in Decatur County, it's in Meigs, but Decaturville is in Decatur County. And like Tipton's county seat is Covington, while Tiptonville is up in Lake County. And the city on the lake, of course, is Hendersonville, while the Lexington closer to home is not in the Bluegrass State, but in Henderson County. Henderson is, of course, in Chester County. Winchester is the county seat of Franklin County, which is, of course, a fair drive from Franklin, the county seat of Williamson. And I learned that if you're in Tennessee, you don't need to go overseas to get to Paris, Sparta, or Athens, which is in McMinn County, and McMinnville is in Warren County, of course. Campbell County has Jacksboro, while Gainsboro is in Jackson County. Jackson is in Madison County, which is a few hours' drive from Madisonville, the county seat of Monroe. Hohenwald, of course, is the county seat of Lewis County. Lewisburg, of course, close by in Marshall County. Bluntville isn't in Blount County, but in Sullivan. Smith County isn't home in Smithville, but Carthage. And Smithville, of course, is in DeKalb. So it's all coming together, as you can see. A lot of, and having to keep all that straight. I haven't gotten the county seats yet, but I'm learning as I go. So really, for all Tennesseans in any rural county, we have staff who are ready and willing to partner with all of you. And our staff provide a tremendous number of services, including all the things that you see here. I think people often don't realize that we provide primary care and dental services. Tennessee is unique in the union in that we're the only state that provides those services in health departments. When I go around and talk to other state health officers, they're often like, you do what? You do primary care? Yeah, we run about 56 locations. So basically, I get to oversee a 56-location primary care clinic with all the stresses that come with that. So those of you who practice medicine, we have to recruit providers, nurses, do all the things you have to do to kind of maintain that clinical stuff. And the dental services, we've had some great success, but the same thing is providing a lot of dental work. So again, one of my favorite stories I often tell is really from Smith County, and the Smith County Health Department has for many years been home to a very beautiful dental operatory. Unfortunately, that fully equipped operatory sat empty for 17 very long years for want of a dentist. And thankfully, we were recently joined by Dr. Andy Bozeman, and in July of 2024, the Smith County Health Department began seeing dental patients again for the first time since 2007. Hundreds of people in Smith County will receive dental health services because of the work of that team, and it's victories like that that I want to keep pursuing. But again, you can see a lot of these things. People often think that we just do, STDs and, probably give out vaccinations. A lot of work, a lot of coordination, a lot of screenings, and we're trying to expand even a lot of the times the things that we're continuing to do for a lot of folks that don't have insurance in our communities. In addition to those services at local health departments, our staff is also fully engaged in a number of activities, things like disease prevention. Oh, this didn't work. Disease prevention, vital records, engaging the legislature, providing access to data, community engagement, running the state lab, which is one of I don't know if we all realize how much of a jewel we have in the state lab here in Tennessee. It's a regional lab. It does work internationally. If there's any bioterrorism or biohazards, we're where those things come and get tested. And we just invested $200 million in a brand new state lab, which is very exciting. We do a lot of things like restaurant inspections. Probably the favorite article you'll read about the Department of Health in any newspaper is, how did my restaurant score? What kind of a grade are they getting? We're the ones who get to do that for you to make sure the food is safe. Maternal child health, engaging a lot of young people and older adults to support healthy aging across the lifespan, and of course, emergency preparedness, and so many more things. And as you can see here, we have a lot of departments that often try to stay in their own lane. And although we have to do our job very well, but we also have to rely very deeply on the success of other agencies across the Tennessee enterprise. Some of the groups I met with every commissioner in every department, and a lot of them said, I've never met with the commissioner of health. Why are you meeting with me? I said, well, because ultimately we touch everybody in the state more than they realize, and often a silent partner behind the scenes, but we touch everyone. And so the success of the Department of Revenue, for example, if they collect monies in, that's going to help health out in the state of Tennessee. If transportation does well, that's going to help health in the state of Tennessee. If all of these departments do well, we move the needle slightly in that. And so it behooves us to be good partners to help them achieve their goals so that we can achieve ours as well. And again, you can see a lot of these here, people like TennCare, who obviously manages a lot of insurance coverage, Department of Mental Health and Substance Abuse Services, which does really an excellent job in providing prevention and treatment in their respective spaces, Disability and Aging, which is a new department, others including Education, DCS, Department of Labor and Workforce, and Economic Development. And we want to, again, be good partners in the state and make sure that people know that we're often the party planners of state government. We convene everybody together to find solutions. Our staff are behind the scenes, often don't like to get the credit, don't like to be in the limelight, but a lot of work that we do. So we continue to work closely with Governor Lee and his team to implement the recommendations really of the Governor's Rural Healthcare Task Force, which is a major priority of the administration and the result of the hard work of many people, really probably in this room as well. In 2024, the governor and the legislature committed to nearly $60 million in funding to directly support rural health. This includes $50 million in competitive grants for rural providers to expand facilities, care delivery, and improve access to healthcare services, investments in a center of excellence to provide technical planning and implementation assistance to rural providers, and continue to work with external partners to expand provider training programs and specialty care services in rural areas as well. Some of that $50 million in competitive grants, I think tomorrow is the deadline. Today is the deadline, 3 o'clock, 3 o'clock today. So if you haven't checked our website, 2 o'clock, 2 o'clock. That's right, 3 o'clock. Yes, thank you. 3 o'clock Eastern, 2 o'clock Central. But if you haven't checked it out, if you're interested, if you can write a grant pretty quick, it might be time today to go check it out. We've got several applications. I mean, I don't know, over 100 applications as of a couple of days ago, and that usually means that it'll probably be double that in the last couple of days. But again, an opportunity to really invest into partners. So it's not just going into more state government, more government. It's investing into the community and those who are providing the care kind of firsthand. One of the main tools or avenues for how this work comes to our communities in Tennessee is through something called community health councils, which have been active in almost all 95 counties over the last 30 years. Anybody here that's been active in a local health council? Oh, that's great. Well, first of all, thank you all. I mean, this is a volunteer, to be part of that, it's kind of a volunteer group in every community, and if you've seen one council, you've seen one council. They're all different because everybody has different focuses, the things they want to get accomplished. So for those of you that haven't been part of one of those yet and are curious, again, they're locally led groups of cross-sector public health champions identifying and advancing a lot of health priorities identified by communities. They use partnerships to address common health challenges, and they're convened by their local health departments and supported by the Department of Health. And they often include folks from local government, from mental health organizations, coordinated school health, the UT Agricultural Extension Office, faith-based groups, many others. So anybody who's interested is welcome in those. And again, a lot of those, they're all very, very unique in a lot of things they try to get accomplished. So right now, almost all counties have gone through some iteration of the county health assessment process in which they establish up to 3 shared priorities, and they work collectively to address them through their community health improvement plans. Ultimately, this is the work of communities improving public health at the local level. I've often talked that this is the engine that's going to get things improved in our state. This project we're talking about with Blue Zones or Sevier County is part of this. It's the same type of project. These people locally saying, we want to get this done. You know, I can come and pontificate, I can wag a finger. No one's going to listen to us often because we're government. But people need to be motivated by their neighbors, by their communities, by their employers, by people that are local. This is how we get these done. These exist in every county in some way in the state. And over the last 2 years, for the first time, we've been able to directly fund Community Health Council implementation projects in 12 communities across Tennessee. And 91% of these funds went to rural communities, with more than 60% going to support projects in at-risk and distressed counties. These projects are impacting substance misuse, mental health, obesity, a number of other issues identified by county health councils. So to build on the success of the work that are being done in those health councils, we have, for the first time, requested $6 million in dedicated state funds to support the work of county health councils. And this funding request is under review right now by the governor and his team, but would expand Tennessee's well-earned reputation as the national model for community collaboration and impact. When you hear about public health transformation, you may have heard that in the news from some states when they pass legislation. This is what they're getting done. We've been doing this already in some way for 3 decades here in Tennessee. So we've been ahead of the curve on that, and when I've had legislators saying, hey, I'd like to do a public health transformation, it's already occurring. We just got to activate them and sometimes fund them and the efforts that are being done. Another 2024 win, Tennessee had the wisdom to reinvest much of its COVID relief funding back into rural healthcare programs, with more than $240 million supporting 90-plus projects through the Healthcare Resiliency Program, or HRP, when you hear me talk about that. These generational investments in healthcare services towards low-income, minority, rural, aging, and other underserved populations in more than 50 counties across the state. And this program has meant so much to our healthcare partners in Tennessee that in 2024, the legislature dedicated, again, like I mentioned, another $50 million in additional from TennCare savings towards a new state-funded healthcare resiliency program targeted to our rural communities. And we expect to make award announcements again in the upcoming weeks and hope that the General Assembly will continue to make these critical public health investments into these as well. Another thing is a stronger safety net is a win for all Tennesseans. When Governor Lee took office in 2019, the Healthcare Safety Net program got about $8.4 million in recurring state funds. Since that time, the administration has increased recurring state funding to the program to $31.1 million. This nearly 400% increase in funding is a direct investment in improving the lives of some of the most vulnerable Tennesseans that we have. It's expanding primary care and dental service offerings through 103 providers to uninsured Tennesseans through over 341,000 patient encounters. And in 2019, Project Access provided only care coordination services, but after the administration's investment, Project Access now provides additional specialty care services through a network of volunteer physicians, hospitals, and clinics in all Tennessee counties. And our program estimates that over $875 million in donated healthcare services provided by roughly 8,000 volunteer physicians and 63 hospital campuses coordinating for patients from over 300 health centers and clinics statewide. And in FY24, Project Access provided services for over 18,000 patients. Reimbursement rates for primary care patients have increased from $20 per visit to $68 per visit in 2024 in just a 5-year span. And dental rates have improved from $20 per visit in 2019 to $92 per visit in 2024. In the last few years, the department has utilized safety net funding to implement a quality improvement incentive program for safety net providers. And the goal is to improve clinical efficiencies and patient health outcomes. And again, if providers are willing to participate in that, they get a booster in their payments as well. Another 2024 win, we are so excited to be announcing that we are, again, like I mentioned, breaking ground on a brand new $200 million, 180,000 square foot facility that will expand the capacity of our incredible Tennessee State Lab. The lab hosts a nationally recognized newborn screening program, and in 2024, the State Public Health Lab's newborn screening section tested over 95,000 specimens from Tennessee babies. The facility is going to sit on 4.4 acres. It represents a 30% increase in size, providing ample size and space for both equipment and people, and the facility will provide a more efficient and safer workflow, Features a lot of modern design, which will more easily transition into surge testing space when needed. And the new lab marks a significant milestone in our commitment to innovation and investment in Tennessee's future. This is a big deal. Coming from Kentucky, I advocated for this in Kentucky. A lot of legislators, don't want to put that investment. Now it's falling apart, saying, where are we going to get the money? You have the opportunity for the money. We had the foresight here in Tennessee from the governor, the legislature, to make this investment, and it's going to be paying off for generations to come. We also strive to make the department the best place to make a difference in our communities, and our success begins with our workforce, really. MondaysMatterTN.org. If you kind of go on this QR code, you can kind of see it. It redirects to the department's job site, and in the first months of this campaign, we've already seen a 300% increase in traffic to the careers page at the department. And in the last 2 years, we've doubled the average number of applicants for TDH positions. Additionally, over the past academic year, the department has nearly doubled the number of internships available for students. 81 interns completed an internship with us this past academic year, where the number was 45 for the previous academic year. So fortunately, we're hoping that we'll start to appeal to the next generation coming up and to know that the work that we do is mission-driven. The folks that are in our department don't do the stuff for the money. They could do better in the private sector. They do it because of the mission and serving people in their communities. Another big recent win for us was our investment in improving maternal and child outcomes through the Tennessee Strong Families Initiative. Part of this initiative was an investment of $5.6 million in recurring state funds with the Department of Health to amplify current programs and offer new and innovative solutions for improving health outcomes to some of the most vulnerable populations. This investment in the department allowed our Family Health and Wellness Division to improve outreach efforts in a few important ways. Through CHANT, which is, again, very unique to our state. It's an enhanced care coordination program that's targeted the areas of the state that have the highest poverty levels, highest rate of sleep-related deaths, the highest rate of SIDS, and the highest rate of pregnancy-associated mortality rates. And it'll serve approximately 2,000 expectant and or postpartum women and infants. And we're investing in perinatal telehealth services because 2/3 of Tennessee counties don't have a birthing hospital. So through a competitive process, the department has entered into 2 agreements to expand perinatal telehealth services targeting high-risk counties in East and West Tennessee. An estimated 2,000 women will be served through these contracted agreements, while additional families will be served through increased support of regional perinatal centers. And finally, the doula pilot project is currently providing doula services to an estimated 300 Medicaid-eligible pregnant and postpartum women. That's an opportunity for us to lay down a lot of data to see what's best practices there, and to consider if we want to allow that in the state of Tennessee in the future. One more win from this year, and it's close to my heart, is my vision for public health to achieve similar success in the prevention and mitigation of Alzheimer's disease and related dementias, and as we've achieved in areas of tobacco control and infant mortality reduction and the near elimination of many vaccine-preventable diseases. Tennesseans 60 and over are the fastest growing segment in our state's population. In less than 10 years, older adults are projected to outnumber children for the first time in U.S. history. Alzheimer's disease is the 7th leading cause of death in Tennessee, leading to roughly 3,000 deaths from Alzheimer's disease each year. And here in Tennessee, more than 130,000 people aged 65 and older currently have Alzheimer's-related dementias, with 370,000 individuals serving as their caregivers. I want to quickly highlight some of the important ways that the Tennessee Department of Health is supporting older adults and supporting healthy brain development across the lifespan. In October of 2024, we were proud to announce the launch of our department's first Office of Healthy Aging to promote partnerships and public health practices supporting the well-being of older adults and caregivers. We've also established a new state dementia director, which is a position that we haven't had before, but I think 26 other states had, and we want to be able to coordinate efforts across agencies and to give Tennessee a seat at the table with our federal partners where other states are convening. We're also putting into place an age-friendly public health system. Older adults and healthy aging activities are included in the Tennessee State Health Plan, our department's 4-year strategic plan, as well as being incorporated into local community health improvement plans led by our community health councils. Trust for America's Health. We have an age-friendly public health systems program that embeds age-friendly practices into public health to advance healthy equity for all older adults through accessible, inclusive, and preventative care across the life course. And the Age-Friendly Public Health Systems Recognition Program evaluates local efforts to ensure that older adults are considered in county-level needs assessments and other health improvement plans. And to date, 26 of our county health departments are recognized as age-friendly, including all 7 counties in our Northeast region, which is a big deal. In 2025, we will be working for universal recognition of every county in the state. Right now, the leading state on that is Florida. I want to beat Florida. So I told our team we're going to have every county try to get this done. Some are taking a bit longer, but they're all looking into this program. And additionally, we're also training a lot of healthcare providers in early dementia detection and diagnosis through the Tennessee Dementia Echo program in partnership with Vanderbilt University. We're also establishing the Tennessee Dementia Navigator Program with local health departments, with 6 navigators that have already been hired. And you say, what would a navigator do? Right now, I think if someone comes down with dementia and you go see your doctor, they might do a screen and go, you might have it, you might not, I can't tell. We might start you on you need to go see a specialist, a neurologist, psychiatrist. If you're going to see a neuropsychiatrist right now, the wait is anywhere from 9 to 15 months to see that person. If you get in to see them, they'll say, oh, yeah, you've got the right, boy, I wish I would have seen you 9 months ago. We could have started you on a medication that really would have halted this, but now you're too far out. And so trying to expedite that, we're trying to get a lot of our providers through the ECHO program to feel more comfortable with that, and then also to have our navigators, when people say, I don't know where to go, where are resources, where can I go for these things, to tie them into those resources. Because there's about $3 billion of investment that's available in the state of Tennessee, and people just don't know how to access it. And when you go to a hospital, you go to a doctor, I'm one of those. When I was there, people would say, what can I go talk to a social worker, go talk to someone, and a lot of those folks don't know. We want to make our health departments the health information center for people when they don't know where to go, where a family can go to be trusted to sit down with someone, spend their time, and go through all their things. Say, let's talk about your advanced directives. What do you want when that time comes? Let's protect your finances to make sure you don't get scammed out of your funds. And to be able to have all those things and have those discussions in detail where our doctors are trying to diagnose and treat, they can have someone they can rely on to refer them there and to be trusted. And you've already got a lot of those things established here in the Northeast, which is very, very good. We're also trying to enhance East Tennessee State University's multi-sector plan for aging dashboard. That's also tracking a lot of aging metrics and trends. If you're interested in that, if you could find that website, really cool to see what's happening in your individual counties as well. And to build on this work in 2025 and beyond, we're asking for an additional $7 million in state funding to support a memory care assessment network to improve early diagnosis and treatment of dementias. This is going to support improved training programs for primary providers serving patients with dementia, continue to expand our Dementia Navigator program to provide a lot of personalized care management and coordination statewide. And it would also be a cooperative effort with our partners at the Department of Disabilities and Aging. The Memory Care Network is something we stole from Georgia, which tried to get this established. We have certain locations where you can get those specialty visits done, but for a lot of folks in rural communities, it's a long drive to have to go to Vanderbilt or to have to go to UT. Chattanooga has a specialist there. If we can create a hub and spoke model where we have locations that are satellites of those very specialists in a rural community and have it really close, people can travel there much more easily, get those evaluations done, get the protocols established, start to get treatment done, and to have a quicker initiative. So we're hoping about $4 million will go towards that. And then again, our navigator specialists, we hope to have an additional 37 navigators that can be spread to every county to provide services in every county. And again, we have a footprint everywhere, and we often tell the governor and a lot of other departments that we can provide services close to home for people because it's a place that they know and people in their community. So again, before we jump into the data, I want to acknowledge that there's probably a lot of uncertainty right now about the role of the federal government on public health in the next 4 years. People are very nervous. In government, people tend to get nervous. I think when I came into this role, they said, this guy was a politician. What's he going to come in here to do? People were worried if I supported vaccines or not. There was a lot of these concerns. And I go, look, I've been on the record talking about, yeah, but we thought you might fold under pressure. I go, no, I don't fold under pressure. But whenever there's change in state government, in federal government, people get very, very nervous. And I think right now, I think it's a time it's of tremendous interest for us. We talk about, we've been talking about healthy eating, getting exercise, all of these topics for 100 years in public health. And again, people just go, yeah, whatever. I'm going to eat what I want to eat. Don't tell me what I should do. And that's often the response we get, but we keep promoting it, hoping that the people who do listen, it'll make a difference on those things. Right now, we've got individuals that are being nominated that have captured the national attention on what we should be putting into our bodies, how we should be eating, we should be exercising. And I find it to be a very unique moment because I've never seen it when we have 20-somethings talking about these things, suddenly interested in these things. What am I feeding my kids? What am I putting into my own body? I don't want to put bad chemicals. I don't want bad outcomes. We've been trying to get that attention, I guess, like I said, for 100 years. So what's the price? What's the value of that? I don't know. It's almost invaluable. There's a lot of discussions about vaccinations and a lot of discussions about fluoride, and you're going to hear some of that information here I'm going to present to you in a second. But I often tell our scientists within our health departments, a lot of people get very emotionally attached to science. They say, this is a pillar of what the Department of Health, these are pillars of what we do. It's got to be right. It can never be changed. And for those of you who are providers in the room, 25 years ago, if you were treating heart failure and you gave somebody a beta blocker, it was considered a malpractice. Today, if you don't give them the beta blocker, it's considered a malpractice. Heart failure didn't change. Beta blockers didn't change. The science changed. We kind of studied and watched somebody challenge the status quo and said, you know what? We should have been doing it all along. And we adapt. No one got upset. If you were a woman postmenopausal 30 years ago, I was supposed to give you hormones to prevent, osteoporosis and prevent hip fractures, until someone said, we're seeing some things happening from this. It was studied and said, hey, we shouldn't be doing that anymore because it can cause breast cancer and other problems, and so we don't do it anymore. So we learn, we all evolve, we challenge the status quo, we learn new things, and we evolve. Things like vaccines, which have been stalwarts for decades, fluoride, where the data is pretty strong, but it's been around for decades. What would it, if you can get someone in who's going to focus on better eating, better healthy foods, exercising, getting healthier, and you have a generation paying attention to that in America, what is the price to be re-challenged on vaccines and re-challenged on fluoride? If the data is strong, as scientists, we should welcome that, because that's how we grow, to study it, to look at it, and if it's confirmed, then we're doing the right thing, great, and if we're not, learn, adapt, and change. I've had a chance to talk to some of the folks in DC who are contemplating these changes, and I've told them, if you want to do that, great, study it, but be fair about it. When you get elected or appointed, it can make you legally correct because you get to make the laws, and you be politically correct because that's the whim of the country of who puts you in power, but it doesn't necessarily make you scientifically correct. And if you want to do that, reestablish science, study these things in detail, produce good studies, and make sure that everybody's involved at the table. And I think if we can do that, it can quickly rebuild the trust of the country back on the things we want to get done. There's likely going to be a lot of energy around a lot of policy at the state and the local level also, and you probably already heard me talking about a lot of things about what we're trying to do to promote public health at the state and local levels. But again, what the public's made clear is that I think it's true, that the status quo in American medicine and public health isn't enough right now for us. If we keep doing the same things over and over again and hoping we're getting different results, we know what the definition what word that defines. We've got to change. And if it means sometimes making everybody very uncomfortable, I think it's an opportunity to do that. I think I have a quote here from David Jarrett, who's the Nashville healthcare leader and a former CEO, who said, "To effectively and persuasively tell your story, you must meet people where they are and acknowledge and address the issues that are most important to them with clear language that they can appreciate." That's called politics. And 1 in 6 Americans say that they have avoided seeking the healthcare they need for fear of its cost. Do we get that? Do we understand the political and the emotional power behind that? Can we speak to that fear plainly with our own passion for the mission to which we have dedicated our careers? In effective messaging, emotion must meet emotion. Leaders must acknowledge the concern as real and valid and meet it with an expression of their personal drive to address. And yes, it's a problem. Yes, we see it too. Yes, we're on it, and let me explain. Instead, healthcare leaders, it's this. You shake hands, you go to a Rotary, you round the halls, you look people in the eye, and you tell stories about your kids, have slow conversations over coffee. And healthcare is a uniquely human business. Bring your human self to your important engagements. Tap the strength of being real. I believe in that. That's all I know. Very plain conversations with my patients when I have them, and you meet things where they're at, and people typically appreciate that. They just want to know what's up. They want to know what's real and who to trust. And that's how you develop that trust, which is ultimately the game that we're in. All right, so just kind of public health. Here we are. This is what side I want to get to. So I want to talk through a comparison of the United States and some of our peer countries. And this is a chart from the Financial Times of life expectancy by income distribution, with England in blue up top and the United States in red down below. And on the left of the chart are the life expectancies of the bottom 1% of earners, and on the right, those in the top 1% of earners. And what this shows is that Americans die earlier than British across the entire income distribution, especially at the bottom end where the gap is more than 5 years. However, we have to consider that most US households have significantly higher incomes than our British counterparts. So if we make the same comparison looking at real income, the US shifts to the right, given our higher relative wealth than those in Britain. And now we see a gap of 5 fewer years, even amongst folks making 6 figures. And to the far right of the chart, we see just a handful of extremely wealthy folks in the US achieve the life expectancy of the most high-income Brits. So the question is why? Increasingly, we're recognizing that this mortality gap is taking shape in early life, when interventions are still relatively cheap and potential impact is extremely high. And compared to peer countries, Australia, Austria, Canada, England, France, Germany, Japan, Netherlands, Sweden, and Switzerland, the chance of a 5-year-old dying before reaching the age of 40 is 4 times higher. The main cause, according to the study, is that young people are dying from external and mostly preventable causes. Perhaps counterintuitively, but encouragingly, the graph on the right shows that for folks who have made it to 75, the life expectancy curve is roughly similar to the United States. And again, this is a chart of a mortality rate by age. To put a finer point on this, in the United States, most of our mortality gap relative to our peer countries comes in young adulthood. This is when prevention and interventions are incredibly cost effective. And as Frederick Douglass once said, it's easier to build strong children than to repair broken men. So again, that's some of the challenge that we have, that as we get older, we seem to be able to match up with some of that. Now, the good news is that medicine and public health have been two of the greatest forces for improving the quantity and quality of human life in all of history. Over the last century, we've gained 30 years of average life expectancy. About 25 of those years are attributable to public health interventions. And heart disease and cancer are still our #1 and #2 killers, and are responsible for roughly 60% of deaths most years in Tennessee and in the United States. So let's zoom back in a little bit. If it didn't go forward. Well, went too far. There we go. Okay. So we want to look at a little bit of how different communities in the United States are faring right now. And this chart's critical for rural health and for our department, which manages 89 rural counties. It's a little busy, but let me kind of explain it to you. This graph shows the death rates from 1980 to 2020 for adults aged 35 to 64 in 4 different types of communities. Major metro suburbs are in pink, consistently have our lowest death rates. Major cities are in purple, small cities are in light green, and rural areas are in dark green. So starting at the left of the chart and moving right, you'll see that in 1980, death rates were broadly similar across all 4 groups. But in the 1990s, we see a steep improvement in the fortunes of city and suburban residents as those lines shift down towards better health. Meanwhile, the green lines representing small cities and rural areas start shifting back to the top of the graph. And this is the point at which rural residents began dying at sharply higher rates than their counterparts in urban regions. And once again, that gap seems to be increasing. So at the end of the day, adults in rural areas and small cities are dying at higher rates than they were more than 40 years ago. Much of this was before COVID-19. With that in mind, and again, as a man of strong faith, I often mention Matthew 25, in which Jesus says, "What you've done unto the least of these, you have done unto me." Our department serves primarily rural and underserved areas, and these are the areas that face the greatest challenges right now. And this graph shows the gap in the death rate for the poorest counties in America in purple up top versus the wealthiest in America below in gray. In the early 1980s, people in the poorest areas were 9% more likely to die each year than their wealthy counterparts, but that gap has widened significantly over time, and in 2020, individuals in the poorest areas were 60% more likely to die each year relative to their wealthy counterparts. In public health, we often talk about the social drivers of health, which means access to housing, food, transportation, and a quality education. And I can only do so much in my own clinic for someone who doesn't know where their next meal is coming from. By improving access to basic needs and improving the social drivers of health and quality of life, we can begin to move upstream and prevent substance misuse and other bad health outcomes for communities across income levels. Now, this particular map is from a 2024 article in The Lancet about local health outcomes. The darker red, the worse health outcomes. You have all probably seen 1,000 maps that look something like this, but I want to put our challenges in Tennessee in a larger context. Tennessee stands in a geographic hub of several areas that in the American Southeast, but also contains portions of central and southern Appalachia and the Mississippi Delta region. And none of these regions are homogeneous and all face significant long-standing barriers to achieving health outcomes to match those of their peers across much of the rest of the continental U.S. And I'd like to lay out a little bit of how we see that challenge moving forward. I mean, we aren't really very afraid to own up to our poor health outcomes. I go around and talk about these all the time. I appeal to the pride of our legislators, to the pride of the governor, to the pride of the state. We're very proud in Tennessee. We're top 10, top 5, probably arguably, financially and tax structure and growth. 2.5 million people have moved into Tennessee in the last 30 years. They're estimating another 2.5 million just into middle Tennessee in the next 30 years. We have a great football team, baseball, basketball. We're great at all that stuff. We're bottom 10 when it comes to all these categories. And this is the last economic pillar that our businesses need to do to be able to achieve the status that we want to have as a state. So again, we're not afraid to own these. I talk about these all the time. We also know that we have the leadership, we have the knowledge, the resources, and the determination to make steps in the right direction. Again, so I want to lay out some of the biggest challenges that we see right now and just a couple of the ways that I see our department helping to address a lot of those. Challenge number 1, I don't need to remind anybody in this room that we face the highest vaccine hesitancy in recorded history. Quoting from a study published in May 2024 in The Lancet, looking at the success of the 1974 Global Vaccine Expansion Program. Since, again, this is a direct quote, since 1974, vaccination has averted 154 million deaths, including 146 million among children younger than 5 years, and of whom 101 million were infants younger than 1 year of age. For every death averted and life saved, 66 years of full health were gained on average, translating to 10.2 billion years of full health gained. In 2024, a child younger than 10 years is 40% more likely to survive to their next birthday. Why? Fewer deaths, almost all amongst children, by measles, tetanus, pertussis, tuberculosis, flu, polio, diphtheria, and other diseases. There are some folks in Tennessee who have had some reservations about vaccination as well. And in just a decade, Tennessee went from being a top 10 state to a bottom 10 state in childhood vaccinations. One of our key measures is the percentage of public school students fully immunized as they enter kindergarten, with a goal of at least 95%, because below 95%, we start to see the power of herd immunity waver against things like measles. In the school year beginning in 2019, we had 72 of 95 counties achieving their vaccine goal. By the school year beginning in 2022, we had just 26 of our 95 counties achieving their vaccine goal. I mentioned that below 95%, we're opening ourselves up to disease we haven't seen in a while, like measles, but also to vaccine-preventable diseases such as things as tetanus and polio. And you can see an image on the middle there, that person that's arched. That's a guy with tetanus. It's a soldier in I think the 18th century who developed it. Imagine having a body spasm in every muscle in your body, all contracting at the same time, or a Charlie horse everywhere. That's unbreakable and you can't stop, including your diaphragm, so you can't take a deep breath. The contractions are so hard that you break your own bones from the contractions. That's what that is. We haven't seen that in this country in a long time, but that still exists in parts of Africa where kids don't get it, they get exposed to something, and they develop these problems. Polio, we just had the last iron lung person pass away, but we've had new cases of polio popping up in Florida and other states now because of kids who haven't chosen, or parents haven't chosen for vaccination for their children. They get exposed to those and can lead to bad outcomes. And we know measles, we've had a couple of cases here in Tennessee this past year as well that we've been tracking. The one county, and I highlight there, is Wayne County. I don't know if anybody's from Wayne, probably too far away from Wayne County. That's the only county that improved in their vaccination rates. I suspect it's because the denominator went down, so you probably had a higher percentage mathematically. For you data nerds, you'll get that joke. That's what I think probably happened there. But we're working very, very hard to try to, again, continue to talk about these and to let our doctors know, to remind them what these diseases look like. I don't have one up here called diphtheria. You probably have heard of diphtheria. We haven't seen that in a very long time. President Lincoln's son died from diphtheria. Napoleon's wife, Josephine, died from diphtheria. This is something that didn't spare people. It's like having a nasty infection in the back of your throat that creates such a thick membrane that it coats your airway. It's like having saran wrap put over your airway and telling people breathe through that. You choke to death and die. It's a miserable death. Again, we haven't seen that, but the risks are going to be coming back. We see those rates drop too low. Our second challenge, tobacco, was and is our greatest cause of preventable morbidity and mortality in Tennessee and in the United States. And estimated smoking rates range from a low of 13% in Williamson County to a high of 30% in Hancock. Here we see a prevalence of current smokers over the last decade. While smoking has dropped slightly for adults, the Tennessee youth have seen a reduction of more than 75% in the consumption of combustible cigarettes. And that's a stunning achievement. That really is very good news. And unfortunately, most of those gains are now being negated by the increase in vaping and e-cigarettes, particularly amongst our younger individuals and younger citizens. A recent paper published in the New England Journal of Medicine compiled and analyzed 107 studies comparing the harms of e-cigarette use relative to conventional smoking of combustible cigarettes. Now, many of you probably know back in 2008 when vaping came out and e-cigarettes came out, it was, well, it's less harmful than tobacco. We've heard that narrative, and the tobacco industry did a really good job of pushing that out, and everybody said, yeah, it's not as harmful. It doesn't hurt you as bad. Our kids say, yeah, it's no big deal. It's just water vapor. It doesn't hurt us as bad. Well, now we've got studies to show that that's not the case. What the meta-analysis showed was that the current e-cigarette versus combustible cigarette use were driving similar risks across a number of different disease states. They found zero difference, no difference, in risk of cardiovascular disease, stroke, metabolic dysfunction for individuals who use e-cigarettes versus traditional cigarettes. Furthermore, the risk of illness for dual users, people that were using both, also increased for all outcomes relative to people who just smoke cigarettes. So if you're somebody who's smoking a cigarette and you're using e-cigarettes on top of that, it leads to even higher rates of heart disease, stroke, asthma, COPD, oral disease than those who just smoked combustible cigarettes. We have to do more in Tennessee to continue driving this tobacco initiation down. I'm saying it's not harm reduction, it's harm initiation is what they're doing with vaping these days. We have to disincentivize Tennesseans from taking up nicotine addiction through e-cigarettes, which is devastating to really good health. In the US, estimates based on the National Cancer Institute Surveillance Epidemiology and End results called SEER data suggest that approximately 1 in 2 men and 1 in 3 women will develop invasive cancer within their lifetime. Cancer is also a large and growing source of economic burden, with projections based on population growth suggesting an increase of $246 billion by 2030. This is a graph that looks really complicated again, but demonstrates with data what I think we already know intuitively, that catching cancer early matters. It matters a lot. It matters in being able to address the disease, it matters in quality of life for patients and caregivers, and it matters in expenditures. This particular study included more than 20,000 eligible patients across 4 different types of cancer: breast, cervical, colorectal, and lung. And the mean cost associated with catching those cancers in stage 1, 2, 3, and 4. And what does it tell us? Early detection saves patients in the healthcare system a whole lot of money. And these are important for Tennessee because we have a fairly robust breast and cervical cancer treating program right now, but we don't have a similar system for colorectal and lung cancer. And lung cancer remains our #1 cancer killer in Tennessee. Only 4% of eligible Tennesseans who can get a lung cancer screening actually get them done. Part of our objective is to try to get that improved. So right now what we're asking for is $2.2 million in state funds to address lung cancer, to catch it early, similar to our breast and cervical cancer programs. And this program, we estimate, could impact at least 7,000 people across Tennessee. We think it's ultimately a very sound investment to address one of our leading causes of death, particularly in our rural counties. Challenge number 3, I'll introduce with a win and then with an opportunity. Tennessee ranked 45th nationally in population to dentist ratio, with 89 counties designated partially or fully as dental health shortage areas. Estimates showed that the state needed 700 additional dentists to meet current practice standards. And to improve dental access, Governor Lee and the legislature invested $94.4 million over 5 years to expand class sizes, services, and provider recruitment incentives. And this program is already seeing incredible results, and recurring funding ensures these achievements are permanent. To build on the success of this pilot program, we're asking the legislature for an additional $24.2 million in recurring funds to support dental school efforts at maintaining expanded class sizes, maintaining ongoing clinical rotations in dental operatories, and to provide high-impact services to seniors and other underserved populations. And finally, ultimately, to provide recruitment incentives that will continue to place dental professionals in rural and underserved areas. We've also asked for an additional $3.4 million that would add LMU to this program and support expansion of their class size and their services as well. So that's the win. Let's talk about a very related challenge. One of these is fluoride. Fluoride is one of the most abundant naturally occurring minerals found in groundwaters throughout the world. It's typically measured in milligrams of fluoride per liter of water, or as part of fluoride per million parts of water. And the normal range is 0.1 to over 5 parts per million. New guidance implemented in 2015 advises community water systems to adopt a uniform concentration of 0.7 milligrams per liter of fluoride in drinking water, a change from the 1 milligram. So it's been recommended to drop it down, ensuring that cavity prevention benefits while minimizing a lot of the risks of mild dental fluorosis. Therefore, a lot of public water systems nationwide commence fluoridation at the recommended 0.7. That's what we do here in Tennessee as well. But I want to show you also, it's interesting there, you look at the ocean. People often worry about being exposed to fluoride. If you go to the beach and you get a mouthful of water, you're probably getting double the exposure of fluoride than you would from anything that we get in the public water supply. If you get a well and you haven't had it tested, you might have a lot of fluoride in your water that comes naturally. And again, this is the 13th most abundant mineral in the Earth's crust that we have, and people are very concerned about these things now. But the impact of fluoride in water and toothpaste, this is the why that we recommend this. Over a 50-year period from around 1960 to around 2010, the number of adults who had no teeth, who were edentulous, or who had lost all of their teeth went from 38%, almost 2 in 5 adults, to just 6%. This is widely attributed to the impact of widespread utilization of fluoridated water and toothpaste at the recommended level of 0.7 parts per million. The progress in dental health from fluoridated water is widely cited as one of the top 10 public health achievements in the 20th century. And again, people often talk about, safety is not really a yes or no question. Almost anything can really be harmful. We always hear about doing things in moderation. You can, again, this is an Indian mom who was out snorkeling with her family, out having a nice time, felt dehydrated, drank too much water in a brief period of time, and had water toxicity and passed away as a result of drinking too much water too quickly. So things as simple as that, and it wasn't because of fluoride. It was, it was bottled water without any of that in it. But again, safety is not really a yes or no. We also look at sometimes concentration, and I point you to the highlighted areas here in this slide that acute fluoride toxicity occurring from the ingestion of optimally fluoridated water is basically impossible. You'll drown first. With water fluoridation at 1 milligram per liter, an individual would have to drink 5 liters of water for every kilogram of body weight. So if you're an adult male, you weigh 155 pounds, it would require that you consume more than 350 liters, or about 93 gallons of water at one time to reach an acute fluoride dose. And people are saying you're going to get exposed to the, you drown from the 93 before you get to any kind of concern about fluoride. But these are some of the arguments that we're seeing that are out there. But more importantly, the fun part is that we get active and current data on a lot of things. These are two Canadian cities that were once fluoridated. And we take a look at Calgary and Edmonton. And you kind of take a look, and they said, both of them decided, hey, do we want to keep fluoride in our water or remove it? And Calgary decided, they voted several years ago, we're going to take fluoride out of our water because we think that's the right thing to do. It's going to save us a bunch of money, and that was their focus and their concern. So they took a look at this over time, and you can see what happened. This is over a fairly brief period of time, 15 to 20 years or so. Both U.S. and international studies have shown that water fluoridation helps prevent 2/3 of hospital kind of general anesthesia dental treatment. And after removing fluoride, the number of dental treatments receiving general anesthesia nearly doubled in just 7 years in Calgary. In Edmonton, the number stayed basically unchanged. And anesthesia, of course, not only prevents potential medical complications to children and adults, but also costs up to $15,000 per child. So they saw these numbers. Calgary said, crud, we made the wrong decision. So they've already taken a vote to refluoridate their water supply, and they'll be doing so in the first quarter of 2025. So people often wonder, again, on a lot of these things, is it really safe? Are we doing it? What happens if we don't do it? We've got real life, current, modern day examples of what happens if we don't continue those programs. The other thing is also that fluoride provides an extra benefit in that every dollar invested saves an average of $32 per person in avoided dental treatment. And the cost of this is about 50 cents per person per year is what it costs for us to do it. So the return on that, again, is tremendous. And again, a great way to benefit anybody. Again, the National Institute of Health, reaching more people with fluoridation not only benefits the entire population, but disproportionately benefits economically vulnerable groups that lack access to regular dental care, and sometimes don't have access to just things that we often consider no big deal to get toothpaste and toothbrushes. A lot of folks, you'd be surprised how many don't have access, don't know how to do things properly, can't get out to have somebody show them how to do those things. All right, and the fourth challenge, yeah. Mhm. Mm-hmm. Yeah, so I mean, the dental fluorosis, I think they've taken a look at that, and that the amount that they've taken a look at, the studies that are out there on those are not very particularly strong. But there is a lot of studies on that. I mean, there's people that are looking at IQ levels on those matches and those concerns. I don't know that that's necessarily been proven through studies that are out there. There's concerns on those. Those are going to be taking long-term studies. You have an opportunity to look at studies like this. So if you were concerned about tracking IQ levels, but that hasn't been proven in the studies that are out there for fluoride. So obviously it's the other concern is, what does general anesthesia do for IQ for a child? If you have under general anesthesia, no one studied those things as well, but the more times to put somebody under, the risks of some of those things are very, very high. We know that there's, yeah, but if you have bad teeth and you have to have them extracted and have to go through that, those rates are markedly increased. And I know that's a debate, and people are not believing that, but I'm not sure that the science is solid on that as part of the issue. And again, those are things that are going to be argued, and you have to take a look at meta-analysis and go back and see what are the IQ rates for that. But I don't think that's necessarily been proven. We've seen that in European studies and people that are out there as far as those concerns with people. But those are claims, again, and like I mentioned earlier in my remarks, I don't have a problem people challenging the status quo to take a look at those things. People say, we think it's causing a problem, and that's how we grow. We evolve and look at that. We've looked at how concentrations affect that. They've had a recent study on some of those recommending lower concentrations of those things. But those things haven't been proven. And that's part of the argument. People question it. What I've told our federal partners is, take a look at that and study it again if you'd like to. But I think the data is we've got 80 years of data for these things and strength on this. And I don't know that we've seen dementia rates increase that we have in 80 years on people that are there. The dementia rates we're seeing is other things besides fluoride, I think, besides vaccinations. There's other environmental things that I think are causing those. It could be microplastics, it could be things in our food supply. And again, those are suspicions. Can I prove those? No. That's where my suspicions would lie for the increased rates of dementia for people that are 70 and 80 that have been out there. And again, it's debatable. People have different views on it, and I welcome those challenges, but it'd be worth taking a look at it. But I can show you at least what dental rates are, and if people have those, again, you get a dental infection, the risks of abscesses, endocarditis, heart valve replacements, lots of those things are going to come from bad teeth and from bad health. The next thing we want to look at is the power of relationships. And challenge number 4 is going to society facing an epidemic really of isolation. I think Dr. Robert Waldinger leads the Harvard second generation study, which began in the 1940s and followed hundreds of individuals over the course of more than 80 years, and is now expanded to include thousands of their children. And the study sought to understand what makes a good life is the question. And while over 200 papers and 9 books have been written about the study results so far, the main takeaway really is a simple one, that the happiest and healthiest people are those who have good, warm connections to others. So social connection is a fundamental human need, roughly as essential to your health and well-being as food, water, and shelter. These are graphs that are from the American Time Use Survey. If I can get this to move forward. Somebody can hit the forward button for me. Somebody's controlling the computer there. Oh, we got it moving forward, okay. Did it go too far? Or that's the right one, okay. These are from the American Time Use Survey and show who we spend time with as we age. And while there are several interesting takeaways here, I want to highlight the graph on the bottom right showing our increase in the time that we spend alone, especially after the age of 40 or so. Isolation increases significantly as we age to the detriment of our older adult population and to the detriment of all the generations that follow, when we missed an opportunity to learn, to support, and to give back to the generations that laid the foundation for us as individuals, for our families, for our communities, and for our nation over the last several decades. So a friendly reminder, if you're so lucky to be able to call your parents, to call an aunt or an uncle or a sibling or a friend that you haven't spoken to in a while, reconnect, pay them a visit. I imagine it'll be good for you both as well. To tie a few of these challenges together, study after study continues to show the impact of positive relationships as we age on something as specific as improving cancer outcomes. To quote the Journal of Clinical Oncology, what is the price of a happy marriage, a secure family, and a network of well-connected friends within our communities today? These recent kind of research suggests that being single, separated, divorced, or widowed significantly increases the risk of oncologic presentation with already metastatic cancer, reduced adherence to treatment, and greater likelihood of earlier death from cancer relative to people who are married. On the basis of the National Cancer Institute SEER Medicare data from 734,000 contemporary Americans, these data came from the 10 leading cancers, apply to both men and women, and create profound implications for our models of cancer care. Strikingly, the benefits of marriage are comparable to or greater than anti-cancer treatment with chemotherapy. So let that sink in again. The benefits of marriage, or at least having someone in your life, are comparable to or greater than anti-cancer treatment with chemotherapy. From a separate study in The Lancet, a randomized controlled intervention observed 86 women with metastatic breast cancer. They used a 1-year intervention consisting of weekly supportive group therapy with a control group receiving the routine standard of care. The women in the intervention group survived twice as long as those in the control group, 36 months versus 18 months. The U.S. Surgeon General has come out with research indicating that loneliness can have the same negative impact on the body as 15 cigarettes per day. And this graph is adapted from a survey from the Center for American Life and demonstrates how friendships in steep decline over the last 30 years. On the left are the percentage of Americans claiming 0 friends. The number of Americans reporting 0 close friendships quadrupled in the last 30 years, jumping from 3% to 12%. And on the right-hand side are the percentage of Americans claiming at least 10 close friends. And in 1990, 33% claimed 10 or more close friendships outside of their family. And by 2021, just 13% could say the same, but that they had 10 or more close friends. So you need to ask yourself, is this true for you? Do you have more or fewer close friends than you had 10 years ago? Let's talk about the degree divide as well. This is something we see kind of reshape the American electorate in 2024, in which we are also seeing in public health. And this is from a 2024 update to the data we just looked at, comparing friendships from those who have at least a bachelor's degree in blue with those with a high school education or less in yellow. And from 1990 to 2010, the number of college-educated folks who claimed 0 close friends went up 8 points from 2% to 10%. But the number of individuals without a college degree went up 8-fold from 3% to 24%, who now claim 0 close friendships. On the right, we looked at those claiming 6 close friends or more. And in 1990, those without a college degree were actually more likely to claim 6 close friends, with roughly half claiming 6 or more close friends. And by 2024, that number has fallen 2/3 to just 17%. while the drop for those with college degrees is actually not nearly the same. So here's also one thing that we do know, not all, but most Americans do feel like we have at least a few people who support us, with upwards of 85 to 90% of Americans claiming that they have at least one person who would help them with many common tasks, such as giving you a ride, listening to your problems, or taking care of you if you got sick. But what these data also show is an enormous degree divide. College graduates have more people they can rely on. These data also show that college graduates have greater access to places to gather outside, such as parks, libraries, coffee shops, or community spaces, and we know that Americans with spaces to gather have more close friends. So particularly for a group focused on rural audiences, which are less likely to have high levels of formal education, and encouragement to invest in spaces that bring people together would be a good idea. And then finally, I want to remind you that we are better off when we're part of something bigger than ourselves. This is from a study published in JAMA, looking at the link between religious service attendance and lower suicide rates amongst U.S. women. The question was, is religious service attendance associated with lower risk of suicide amongst U.S. women? And in a long-term cohort study, women who attended religious services once or more per week had a 5-fold lower risk of subsequent suicide compared with women who never attended religious services. They go on to note, quote, "Our results don't imply that healthcare providers should prescribe attendance at religious services. However, for patients who are already religious, service attendance might be encouraged as a form of meaningful social participation. Religion and spirituality may be an underappreciated resource that psychiatrists and clinicians could explore with their patients as appropriate." All this to say that it's important, regardless of our faith, to engage with our family, our peers, and to pursue something bigger than ourselves. Remind you that in a lot of our focus on things like blue zones, all the communities had a faith in something more than themselves, that we often don't have to explain everything scientifically on things, that sometimes there are things that are a mystery, and that we have to share that experience with others to explain those mysteries or kind of reason what those mysteries are. And then finally, I want to work a little bit on a little bit about equity. We hear a lot of talk about that, and when I mean equity, I'm not talking DEI, which people hear about. I'm talking about trying to create a level playing field for a lot of folks when it comes to health outcomes. You know, the Cathedral of Santa Maria del Fiore, which is in Florence, Italy, plans were first drafted for that in 1296, and construction began relatively quickly, but the first architect died in 1310, and work came to a halt. Work didn't start again until the 1330s, including construction of the Great Giotto Tower in 1334. Work stopped again when the Black Death hit Florence, killing half the population or more in 1348. In 1360, a new construction lead was appointed. In 1418, the base of the dome was completed. In 1420, the design for a dome with no support systems was approved, and the technology to construct that kind of a dome did not yet exist. In 1446, the designer of the dome passed away. His tomb was discovered under the cathedral in 1972. And in 1471, the dome was finally complete, nearly 200 years after the first brick was laid. Then they could start on painting and decorating the inside of the cathedral, which has continued for the last 500 plus years. Why do I tell you that story? I think because a lot of times the things that we're trying to work on when it comes to creating level playing fields for folks is like building a cathedral. It's not something that we're going to build like a skyscraper. It's not something that we're trying to get done really, really quickly. We're laying down blueprints at this point in time. We talk about equality in our country. When our country was founded, we had the blueprints for equality that were established. Many would argue that country wasn't equal at the time, but we're a lot further along today than we were 250 years ago. Why? Because we had people that put down the blueprints, people argued about what that should look like, and they gradually started building on that. And every generation has passed to the next one. The people who started that didn't see the cathedral at its completion, but we're starting to now look on, when it comes to equality, spires are, the cathedral's basically, it's getting really, really, really close, and people feel very much more comfortable where we are with that. When it comes to equity issues, we refer to things for people that are either in rural communities or in urban communities, often who share very same situations, outcomes and health disparities and things. We're trying to create a system that creates things as equal and as basic as we can and possible for all those individuals. And so as we work on that, I know people are going to argue and fight about what that should look like, and we're just kind of in the early phases of that, setting up blueprints of what that can look like in the future. To have grace with each other as those discussions occur, with people that are supportive or against it, to have those discussions and begin having that building as we try to get to, maybe it will be a beautiful cathedral someday, that as we do that work, we pass it on to the next generation, to the next generation, to the next generation, until we get to a place where everybody is in good shape on that. That was my presentation. I appreciate y'all's attention. I know it's a lot of material to cover and a lot of data. We got a lot of work to do in Tennessee, but I'm pretty encouraged about where we can go. And I think we've got a lot of folks that are committed to that. And again, I commend this community, which is starting, I think, to tackle something that is it's tremendous. I'm really excited about it. Not just because it got on Netflix and people saw a lot of this conversation. It's been around for a long time, but because a lot of the efforts that are getting done to lead to better health outcomes is beginning now. And I think if we can have a community like this that starts doing it, it becomes contagious. Other counties are watching what's going to happen here. You've got your neighboring counties who are already watching. They want to start doing the same thing. We're getting counties in West Tennessee that are inquiring about it. I know Knox County, Hamilton County, they're all looking at this kind of a project. And if you're the first, you can kind of lay it down for Tennessee and to see what happens here. So thank you all for your kind attention. I appreciate it. I don't know if you have any questions, anything you're curious about. Yes? We had very limited funds to start with, and so I've argued to the governor and his team that these are the engines to get things changed. Again, I can come on high and say we should do this, but ultimately local communities are the ones who need to decide and find the energy internally to get those things done. So if the community says, hey, what's important to us here? We don't like our vaping rates. We want to work on those. Hey, obesity rates are too high. Mental health issues, and so, we want to work on those things. Every county has different focuses. So what I can say, from Nashville and saying, hey, these are our numbers. Here's our cardiovascular and our cancer rates. But what might matter to Lake County is going to be different than Crockett. That might be different than than Hancock. They're all going to have different issues. And so the problem is a lot of those will want to get those things done, but they don't have the funding to get those initiatives started. We've got pockets of funds that we can use for a lot of things that might help improve environments. And so people will say, we want to create walking spaces. They'll apply for those grants, but our funds are very, very limited. We've asked for over $6 million from the governor saying we'd like to be able to have a pot of money to help invest in a lot of these councils and what they're trying to get done. And we're hoping it'll happen. Sometimes, you can make a request and it might make people, they might get a little uncomfortable. You have to keep asking. So I often tell our team it's multiple pounds at the rock before it breaks, is that we have to continue to kind of advocate for that. So we put a request in last year. We put another request in this year. The Rural Healthcare Task Force also had recommendations to have funds put in for grants to be used on local levels. And so if we get the funds for that, it'll be available beginning July 1st of the next year, assuming the governor approves it and that the legislature would approve it and that we could use it. But just stay tuned, check with us. I mean, if those do get approved, then we'll have probably several counties who will be interested in applying for those funds. We'll be able to fund hopefully quite a few projects across the state to get things started. Yeah, JW might be able to answer that. JW is my deputy commissioner in charge of he oversees health council. It's kind of one of his babies, I think, that he's really worked very hard over the years really to get developed. But we're hoping if we can find more funds, it's nice to meet and discuss and say, these are the things we need to work on. That's great. But then you say, how do we fix these? And sometimes it takes investments. Local communities are strapped, as are most governmental structures. And so if a local government says, hey, we can't afford it, to be able to have at least some funds available people could apply for is kind of our dream, to be able to help counties get their dreams done on that. Any other questions? My wife's giving me the shut up and sit down. Thank you all so much for your kind attention. I appreciate it, and thank you for the work you're doing here.